Hi, P4 friends. It is Dr. Bree, and we are excited to be talking about childhood atopic dermatitis to round out our 4 weeks of eczematous conditions in children. So we talked about diaper rashes. We talked with Dr. Lamb about the history of atopic dermatitis, which if you haven't seen that, it's fabulous. I learned so much from him. I definitely encourage you to watch that one. Then infantile eczema, and we are going to wrap up this month with childhood atopic dermatitis. So this is a picture of a child, and I know Dr. Lamb talked about this. So this is an African-American child that has significant atopic dermatitis, because when we are seeing this much red in the skin or purple, it means it is significantly inflamed. So this kiddo is suffering terribly. And this is actually The Misery of Living with Childhood Atopic Dermatitis is the title of an article that I pulled this from about the health-related quality of life. And this is kind of insane crazy to me, y'all, but they questioned families that had children that had chronic diseases of childhood, and that included diabetes, epilepsy, asthma, kidney disease, cystic fibrosis, and atopic dermatitis ranks second in the negative impact it had on quality of life, second to cerebral palsy. So cerebral palsy was number one in the negative amount of impact it had on families, and atopic dermatitis came second before diabetes, epilepsy, asthma, kidney disease, and cystic fibrosis. So our patients, when they come to see us, they really are struggling. And again, so many studies, and new studies are coming out all the time just showing the significant negative effects of atopic dermatitis on our patients that we take care of. And that's not just the children, but it's also their families who are also struggling to help these kiddos. And so there's behavioral and emotional aspects. There's, of course, embarrassment, bullying, social isolation, and emotional distress. The big thing is sleep deprivation. And I know I touched on this a little bit with the infantile eczema talk, but these kiddos are exhausted, completely exhausted. And if you guys stay up late studying for an exam, the next night you catch up, or the next day, if you're post-call, you catch up on your sleep. Well, these kids have a chronic condition that's affecting them every day. So there's never catch-up sleep for these kiddos. So they're chronically exhausted, and that leads to mood disturbances. So it's that chicken or egg thing. If you're not getting enough sleep, of course your mood's going to be bad, and you're not going to be able to function psychosocially very well. And same thing for these parents. So the parents, because their children aren't asleep, are going to have problems getting to sleep themselves. And if you ever talk to a family about the sound of scratching, it is something that just throws them into PTSD if they ever hear it again. Like once their child kind of grows out of the atopic derm, when they hear somebody scratching, it just really triggers all these negative emotions that are associated with the eczema. And then it affects their family functioning. So, if you have one child with atopic dermatitis and 3 of your children don't have it, well, you might not be able to go out to the park during the summer when it's hot, because that causes one of the brothers or sisters to scratch, or you can't go to Schlitterbahn because they're too sensitive to the bleach in the water. So again, it really not just affects the child, but it affects the whole family unit. And many studies have shown the decreased well-being. So again, while we are really there as dermatologists to help with the physical aspects of atopic derm, if we don't really address the whole child in these aspects and give them tools to help them, then we're really not helping these families as much as we could be. So the word atopic dermatitis, again, Dr. Lamb taught us this, but it literally translates into to boil over. That's what it means. And when you see a kiddo that is so significantly inflamed, you are going to see their skin almost boiling over. And you can just imagine the weepiness that also comes with that. So again, secondary infection of eczema or atopic dermatitis is very common, but a lot of times it's just that there's so much intense inflammation in the skin that it can't even hold it in, and it just kind of bubbles up and boils up and gives that kind of serous crusting that can then become yellow and stuck on and look a little bit like the honey crusting of impetigo, when all it really is just the inflammation bubbling up to the surface or boiling over. So Atopic derm affects 15 million Americans. It's increasing in prevalence. It's up to about 17%, with a 20-fold increase since the 1960s. And why? There's lots of questions about why, but what makes the most sense to me is that we see this uptick in not just atopic dermatitis, but all atopic conditions, including asthma and allergies and food allergies, as well as autoimmune conditions in industrialized nations. And we're not seeing that in countries where they're not developed and they actually have a lot of infection. So in these countries where they really have true infection and their immune systems are busy with fighting infections, they, I always kind of tell the parents that these kids with atopic derm, their immune system is a little bit bored, like a little kid that's bored and doesn't have anything to keep them occupied. Then they overreact to things they shouldn't, and leading to these atopic conditions then and these autoimmune conditions. So it makes a lot of sense to me that because we don't have as many infectious diseases, that these atopic things are on the rise. So some people actually call that the hygiene hypothesis or the eat dirt hypothesis, basically that we should let kids be exposed to a lot more, and we shouldn't be using the hand sanitizers and all those things, and let their bodies be introduced to these germs early on, these other things, so that they build a tolerance to them. It makes a lot of sense. And there's also another study that shows that kids that grow up on farms, where they're getting a lot more antigenic stimulation by animals and all kinds of stuff that we come in contact with on farms, basically they don't get as much of these atopic disorders, eczema, asthma, they're actually less. So has a lot of good common sense to me, and also a lot of science behind that thought. So basically, we do know that atopic dermatitis is a childhood disease for the most part. Most people that have atopic dermatitis develop it between the ages of 2 to 6 months. But again, like we talked about in the infantile eczema talk, I really like this little girl right here. She's got severe, what I would call infantile eczema, because she's an infant. And they don't yet have food allergies, and they don't yet have asthma. So we don't know if they're really atopic, if they're going to have that atopic triad. But when they're significant like this, those are the ones that usually go on, the 10% that go on to persist with childhood eczema. They are the ones that look like this usually. So you get an idea, but again, I would wait till she's about 2. And if it persists, and she starts to develop some other atopic qualities, then that's when I switch it from infantile eczema to atopic eczema. It is familial. We know that 60% chance of having it if you have one parent who has atopic derm, 80% if you have 2 parents. And then interestingly, same risk if you're preterm or term. Some things are a little bit different in those populations, but not atopic dermatitis. So again, complex pathogenesis, and I touched a little bit on this with the infantile eczema talk, but the skin barrier, again, I always kind of, when I explain it to the families, that their kiddos are born with this brick wall that's missing kind of the mortar in between the bricks. And part of it is when babies are floating around inside in that big pool of water, their bricks are a little bit more open to allow diffusion of nutrients and things that they need. And then again, they go from an aquatic being to a terrestrial being very quickly. And just like, different things in the lungs have to transition with, the birth process, so does the skin. And we know that that filling in of the bricks and mortar can take up to 2 years for it to be maximized. So again, it's no wonder that kids with the children are the ones that get atopic derm, because their barrier isn't, a fully formed bricks and mortar yet. They have all the components, but they're not functioning yet. So again, when you have that open barrier during those first few years of life, that's when the antigens get in. And if you have an atopic kind of diathesis, that's what's going to trigger the immune response, because these basically allergens and irritant shouldn't be in the skin, and then that triggers the inflammatory response. The inflammatory response then happens in the skin, and we know that there's a big interplay with the immune system in the skin, but then also those inflammatory cells go carting off to our lymph nodes, and that's why a lot of these kids that have significant atopic derm do get a lot of lymphadenopathy, and we can see them to be lymph nodes to be quite large. And some people call that dermatopathic lymphadenopathy. But that's what is thought to then cause this atopic march, where those inflammatory cells that are all revved up in the skin get carted off to the immune system, and then the immune system takes them to other places, into the airways, into the GI tract, into the nasal passages. And that's why we then see food allergies, asthma, and rhinitis developing after this peak of eczema, which is what develops first in the atopic diathesis. We do know, because of that brick wall not being a very good barrier, and also then the itchy, scratchy part of it that opens up the barrier even more, we know that most people with atopic dermatitis are colonized, secondarily colonized. And again, that's a fine walk between treating when you think it's truly infected or if they're just colonized. And I always believe less is more, because these kids are going to carry this bacteria on their skin. We don't want to expose them to topical antibiotics or oral antibiotics often, because then they're going to have resistant organisms. So, and we do know that they do have decreased beta defensins in their skin to help with fighting infection. So again, they're already set up. So we really have to be careful about how we treat that, knowing that most of these kids are going to be colonized with bacteria. Then again, that atopic relationship, 50% will develop asthma or allergic rhinitis. And we know that that uptick of the immune system is there in big ways. So treatment failures, these are things to think about. We're going to talk about some treatment tips here, but when your treatment fails, these are things to kind of think about as we go through the different treatment options. But non-compliance, it is very hard for these families to do regular, diligent skincare. And you can imagine that if your baby has open skin and you're putting them in a bathtub and they're screaming and they're crying and flailing around and asking you not to do it, as a parent, not only does that break your heart, but it also makes you not want to be very compliant with doing this. So again, non-compliance is a huge issue in our patient populations. It's also very time consuming, because as we know, daily bathing is important to not just get moisture back into the skin, because it can't lock it in because of the barrier issue. But it also is really important to get the allergens off of the skin, because if we're just moisturizing on top of allergens or bacteria, all we're doing is driving them further into the skin to wreak more havoc. So it's really important for that daily bathing. But non-compliance can happen because the medicines are difficult to apply. So we need to think about those things. The child doesn't tolerate it. And then inappropriate medication use. So there is so much steroid phobia out there. So I do find that if you haven't educated your families well, they are not using enough topical steroid half of the time, most of the time, I would say. And when you go around a patient, so your palm, so your palmar surface area. So if I have a kiddo that has their whole abdomen, maybe 5 of my palms, and then a couple legs, so they might need 7 grams of steroid application per application when they're significantly inflamed. And that's really to put the fire out. That's not something you want to continue, but a lot of times we don't get the fire fully put out because we're not recommending enough medicine, or the parents are scared to use enough medicine. And then maybe they need systemic treatment. Maybe the topical is just not enough for them because their eczema is more severe. Or maybe you have the secondary bacterial infection, and this is a good example of that. So this little one has eczema herpeticum. You can see those kind of punched out ulcers there with the hemorrhagic crusting, very classic for eczema herpeticum. Some people call it buckshot. I hadn't heard that till I moved to Texas, but I really don't know buckshot, but I'm sure some of these people listening do. And I have on a hat, like I should know what buckshot is, but I don't, but that's what it's called. And then you can see it gets secondarily impetiginized, where the staph does overlie that. So again, your therapy might not be working because of either bacterial, viral, or fungal infection. Microbial contamination. I have had families where they're using a moisturizer out of a tub, and basically they have made this tub of moisturizer, even if you prescribe a tub of triamcinolone, they put their hand in there, put it on their child that's colonized with bacteria, put their hand back in there, and then this, because it's got oils in it, is just a big petri dish, and they can contaminate themselves when they reapply their medicine or their moisturizer. And then contact allergens. Again, those bigger proteins are getting through the barrier and stimulating the immune response. And then you might just have the wrong diagnosis. So other diagnoses to consider. So these are just good examples of peri-orificial dermatitis, used to be called peri-oral dermatitis. And you do have to, when a child has this, there's confusing literature on the internet because, you know, there's the childhood variety and then there's kind of the adult variety, and they're a little bit different. But this tends to very much be peri-oral, but peri-orificial is a better description because it comes up around the orifice of the nose, around the eyes, and you can actually get it in the genital and diaper area, and those orifices in that area. So it tends to always be much more papular. So a lot of times it will start out as like an irritant dermatitis, or what some people call a drool dermatitis. We're putting topical steroids on it to treat the inflammation. And then they develop this kind of steroid rosacea or peri-orificial dermatitis. And so it's going to be more papular. You're going to see these fine papules, and we know that topical steroids make it worse. I do find that in peri-orificial dermatitis in children that I like the non-steroidal anti-inflammatories like pimecrolimus and tacrolimus. I think they work better than the metronidazoles and those type of things that tend to work well for the adult peri-orificial dermatitis. Because I think theirs is a little bit more, kids are a little bit more like eczema, and adults are a little bit more like rosacea with this. And then pityriasis rosea, of course, your Herald patch, you can see that well. And they talk about that Christmas tree distribution, which is really, it doesn't happen often, but it kind of goes along kind of the Langer's lines, and starts out with that initial Herald patch. And that's going to be a little bit more papulosquamous and more discrete, as opposed to eczema, where you have a more indistinct border when you look at it. Psoriasis, same thing. It can look a lot like pityriasis rosea, but the scale tends to be a little bit different. And definitely in children, we can see the gut tape variety of it. That's very common in childhood. But don't forget that babies can get psoriasis too. And we tend to see it as very well demarcated plaques, tend to be a little bit more bright red. And again, your atopic dermatitis is going to have more indistinct borders. And then scabies can look exactly like atopic dermatitis or infantile eczema. And it's because the scabies mite induces an eczematous response in the skin. So again, will look a lot like eczema, but it's always going to be involving in kids pretty much the palms and the soles. So eczema, eczematous conditions, atopic derm does not involve the palms and soles for the most part in children. So if you are seeing that, and the baby's really itchy and fussy, scabies is very high, and on my differential diagnosis list. And, you know, they don't get the classic kind of burrows that we see. They just, because you can't see the forest through the trees, because they get such an eczematous response because their skin and immune system is a little bit more revved up. And then this is another one. So when I get a kiddo that has more erosive dermatitis, and it does tend to be peri-orificial and in the diaper area and in the, you know, axillary area. And again, we can see that with the infantile variety of eczema. And again, babies aren't sleeping when they have eczema, so they tend to be fussy. But these kids, because they have a nutritional deficiency of zinc, they really are kicked up a notch fussy. It's not just the typical, oh, I have bad eczema and I haven't slept fussy. These kids are a lot more fussy. You can see all these kids here in these pictures are crying because they tend to be very upset. And it's hard for you to even talk over their crying in the exam room. The other big thing that I think that we miss a lot is allergic contact dermatitis. So it is very common in childhood. And again, we used to think that it wasn't so common. But again, when you have a baby with a skin barrier issue and those allergens are going through the barrier and they're getting repeatedly exposed to these skincare products that have so many potential allergens in them, they have a high incidence of allergic contact dermatitis. And we're finding that more and more. It accounts for 20% of childhood dermatitis. And the top allergens, you know, they change up every few years, but these are pretty consistent. So nickel, cobalt, they kind of cross-react, it almost seems, but nickel can be in the diet. And then of course, neomycin. So many of these families, and if you don't ask, you don't know, but so many are using neomycin which cross-reacts with bacitracin. And then the methyl isochlorothiazolone, or the MIMCI, it also goes by the name Kathon, and that's in so many skincare products. It's like a surfactant preservative, but it is in the Eucerin product line. So that is not my biggest favorite brand. Fragrance is ubiquitous in so many things, and even baby Vaseline has fragrance in it. A lot of people don't know that Balsam of Peru is basically a fragrance, and it's in the butt paste that so many people use. And again, we're putting it on irritated skin that's already open and inflamed and more reactive, and then we're putting a strongly sensitizing contact allergen on inflamed skin. Of course, we're going to have an increased risk. So Balsam of Peru is not uncommon to come up as a contact allergen in kids that have had bad diaper rashes. Lanolin is ubiquitous in so many things. And basically it is in a lot of skincare products. You have to educate your patients to look. Aquaphor is the big offender of this. So that's part of the reason I'm not a big fan of the Aquaphor, because I've had so many patch test positive kiddos with lanolin. And then these last two are also surfactants. They add foaming to sensitive skin products. So cocamidol propylbetaine, it comes from propylene glycol and coconut. So again, those can be big sensitizers. So this is kind of a list that I give families that have kids with real sensitive skin to be kind of on the lookout. So contact, allergy can be very obvious. Like you can clearly be sensitive to adhesive. This was a baby that actually had a reaction to nickel, and that was in the snaps of the sleeper. This looks like lip licorice dermatitis, but this was actually lanolin and Aquaphor, nickel, of course. And then this is poison ivy. You can see the linear pattern. But in kids, you can have very subtle patterns. And these pictures are from my mentor, Dr. Elaine Siegfried. This was a little girl she picked up that, and she had her glasses off a lot of times when she was examining her. And then she had her put her glasses on, and she had gotten these new glasses that tended to slide down, and found to be allergic to nickel. This kiddo is actually sensitive. He was using Eucerin, so he's sensitive to the Kathon or the MCI in it. The school chair sign. This is kind of a fun one. Again, from my mentor, Dr. Siegfried, it's published, but you can see the posterior areas of the legs, and it kind of correlates with the chair or the metal screws that come up into the chair. So that's something to pick up on. So again, reasons why I patch test, and I do patch test a fair bit in children. The main reasons that I do it is any new onset dermatitis that has come on later than it typically does. So if I see an 8-year-old that develops rip-roaring atopic dermatitis, why did that come on? Have they developed a contact allergen? And then progressing or worsening dermatitis. So we're doing all the same things, but it's not working anymore. That's a big, ding, ding, ding in my mind. If they have increasing body surface area where they've never had spots involved, and now all of a sudden they still have their typical spots, but more body surface area involved, specific sites. So periocular, basically kids that have periocular dermatitis have allergic contact dermatitis in my mind until proven otherwise. And you can get an id reaction. So kids get that autoexemization or id reaction where it almost looks like lichenoid. And it tends to be these lichenoid papules that are around the elbows, around the knees. And then you start looking around and you're like, oh, maybe they do have a contact allergen. Recalcitrant dermatitis, like, the family's being compliant, and you have gone over everything and feel like they're doing everything right, but things are just not getting better. And then that id reaction we talked about. So this is an example of patch testing. And this was a kid that reacted to ethylene diamine, which is in generic nystatin cream. And they were using nystatin cream down here thinking this was a fungal infection, and it was just eczema. This kiddo, again, Kathon and Eucerin is a big trigger for that. And this kiddo, you can see that periocular dermatitis. So keys to treatment. And again, this picture speaks volumes to me. This is a kiddo that submitted this in a coloring contest. And it's an older picture because he had a wallpaper border in his room, which is kind of out of style now. Who knows, it'll probably come back in style soon, but you can see it's the middle of the night here. It's midnight. He's laying in his bed sad. He's got all his medicines on his counter that he put on, and his skin's bloody. So keys to treatment so that we can help kiddos like this so they don't have to suffer. You have to treat all the pathogenic mechanisms because, again, this itch scratch cycle is huge in kids. You have to treat the barrier, you have to treat the inflammation, you have to treat the itch, and patient education really is key. And I spend a good long time the first visit with eczema because you don't know what you don't know, and you are responsible for educating your patients. And then again, addressing that psychosocial component is also very huge. So we're going to go into these a little bit as we wrap up here. Treating the skin barrier, again, that's where the whole problem starts. So we have to optimize skincare, and that is what I spend the most time on with my families, is optimizing skincare. So avoiding allergens and potential irritants. I always tell them less is more. The less we put on their kids, the less they're going to react to. And then the other thing is, it's important to tell them about type 4 delayed hypersensitivity reactions. I have that discussion with my families and just explain that food allergies and things are going to give you a type 1 immediate hypersensitivity reaction where you're going to react right away. And we're going to see urticaria in those situations in the skin. But eczema is more a type 4 delayed hypersensitivity, just like allergic contact dermatitis. So many families have tried 50 creams, and they have 50 creams sitting out on their bathroom counter, and they give their kid a bath, and then they're like, oh, I put on this cream last night that I think made it worse. Well, the thing is, because it can take 24, 48, 72 hours to have a reaction, like poison ivy is how I explain it. Like the oil of the poison ivy plant gets on your skin, but you don't have a reaction for a more extended period. You don't see the skin change. And because contact allergy looks just like eczema, sometimes they're blaming it on the cream that they put on the night before, but it might have been the cream that they used 3 nights ago that actually flared them up. So that's why skincare can be so confusing when you don't know what you don't know. And again, if you don't ask what they're using, you don't know. And I will tell you, a lot of families do use triple antibiotic cream with neomycin, and there's so many kids with neomycin allergy because anytime they get a little open area skin, the family's putting neomycin on because they don't want them to get infected. So daily baths. And again, the older literature used to say that baths every day weren't what we wanted to do. But now that we have better skincare products, so if you do a bath the wrong way, yes, you can make the skin drier and worse. But if you do a daily bath and do it the right way, not only are you adding moisture back in the skin, you're getting those, again, allergens off, you're getting the bacterial content on their skin, you're reducing that microbial load on their skin. So daily bath, I always tell the families to make it warm, comfortable, let them play in clear water. I do a dilute bleach bath for kids that are pretty open skinned because I don't like to use topical antibiotics, again, because then we get secondary problems with antibiotic resistance. But for the colonization, CLN cleanser is, expensive, but some people really have a hard time doing dilute bleach. It has to be unfragranced bleach, but I'll do that at least once a week, usually for my bad atopic dermatitis kids, just on a once a week basis. They take their bath, plain water first. Then if they're going to do the soapless cleanser, and I do like cleansers that are soapless. The sensitive skin ones are out there, but you do have to look out for the cocomityl propylbetaine, which is in a lot of them. And then I really believe in the 3-minute rule. And that's basically after you do their soapless cleanser, get them clean, rinse them with clear water, get them out, pat them dry, and then they have to put their moisturizer on within 3 minutes. Now, for little kids, that can sometimes be like almost like greasing a pig because this kid wants to wiggle away from you. So a fun way to do toddlers is to get like a little egg timer that they can watch and count down. Other tips and tricks is you can put a little bit of cream in the kids' hands and have them help you. And this just keeps that, gets them distracted enough that the families can get their medicines on them. And again, we want liberal, bland emollients. Ointments are always better than creams, always better than lotions, just because, again, lotion has more water than oil content, where your cream has kind of an equal amount of oil and water, which is similar to our skin barrier. And then the ointments are the most like our lipophilic barrier. Things that I like, that I found to be helpful, that have less I can recommend any of these, and they don't have much contact allergen potential: petroleum jelly, mineral oil, Vanicream, or CeraVe. I do find that the CeraVe can burn and sting a little bit more. So if I have the young, like a baby or a toddler, I don't like to use anything that has the potential of burning or stinging, because then as soon as they see any type of skincare product, they flip out. But as we get a little older, to the older children, tweens, teens, the CeraVe is a lot more cosmetically elegant, and they don't worry about so much burning and stinging. They just don't want to feel as greasy. Things that I don't really love, again, Eucerin has the Kathon in it. Cetaphil has sweet almond oil in their creams and lotions, and almond oil. Yeah, almond oil in it. And then Botanicals Organic. And again, I just tell families that basically it's taking a bunch of leaves and plants and flowers and crushing them up and putting them in a cream, and then you smear them on a kiddo that has a barrier issue, and they're going to look just like poison ivy to the skin. And then keep it cool and wrap it up. So basically, keeping it cool. Some kids love their moisturizers to be in the fridge, and you get that gating theory of the nerves, where the itchy nerves that were sensing itchy sense cold, and it distracts the brain. And then, of course, wet wraps. We love wet wraps if you can do them. For an acute flare, I think it really helps. There's these physiologic moisturizers, some prescription, some over the counter. I just really stick with the over the counters, but they're available. Treat the inflammation. Topical corticosteroids are the first line. They can be overused. And I have seen kids have HPA axis suppression from using too much topical steroid, and it has to be very closely monitored. I ask my families that if I'm prescribing topical steroids, I don't want their pediatricians prescribing it. I don't want their allergists prescribing it, their pulmonologists. I want to be looking at how many grams over time I'm prescribing. I do believe that sometimes we start too low, and then it doesn't get better, and then you have to raise it up, and then the families hear about steroid resistance and they're worried that you're going up. Well, we just didn't start strong enough. It's better to hit hard, get it under control, use it for 2 or 3 days of something stronger, and then lower it. And you actually get more bang for your buck, and they have more steroid-free days in a year if you use a little bit higher potency, just less often, and it controls the disease better. Steroid holidays are really important. I tell my families they can use topical steroids, depending, if it's a low potency, they can use it 15 days per month. And I usually have them, instead of doing a week on, a week off, a week on, or 2 on, 2 off, I say, use it up to 15 days a month. You might use it 16 or 17 one month, but other months you're going to be using it 5 or 6. So again, it's always better to catch it early before it really gets inflamed. So I tell them if they've gotten it under control, then we really just want to manage with skincare. But if they catch a flare quick, then they can knock it back down pretty quickly with a day or 2 of steroids without waiting till it gets bad and then having to do a whole 2 weeks of it. And it's important to see them back regularly to assess for the response and the side effects. So if a kiddo can't get their 15 days of steroid holiday month after month, that's when I think about adding in topical calcineurin inhibitors, which are technically not FDA approved down to 2, but I use them a lot in infants off-label. But again, I tell the families it's an off-label use. They're FDA approved for eczema, just not at that age. And again, that black box warning, when they first put that on there, it caused a lot of hysteria. But we know more over time that there really is no systemic absorption, and they're safe and effective. I love them for sensitive skin areas, for steroid holidays. And there are some studies that show, and they used, I think it was tacrolimus, where even when they weren't flared up on like the antecubital and popliteal fossa, if they did that 2 times a week, it actually then resulted in them having less flares over time. Newer on the block is the topical JAK inhibitors. They're technically not FDA approved under 12 years of age, but I know that we are using them off-label. But again, they already say less than 20% body surface area because of the potential systemic absorption. And we do have to worry about kiddos because they do have, a greater body surface area to mass ratio. A good in-between from the topicals, I really do like still UVB therapy. I do prescribe at home units. So again, home units of narrowband UVB. you can educate your patient and follow alongside. They can bring you their logs. And there are some companies that will go in and set the phototherapy unit up at home. Systemics, when it's SAD, and that was something me and Dr. Siegfried would talk about, the SAD club, which is severe atopic dermatitis. So when you have a kid that it's impossible to put on creams like they on a regular basis, it just becomes just too difficult. They're getting exposed to too much topical steroid because they're putting it on such a big body surface area. And if you feel like you need to prescribe a tub of triamcinolone, then you probably need to think, if you're doing that regularly, they probably need to be on a systemic. The oldies and goodies that we used to use before we had some of these newer ones, methotrexate, cyclosporin, azathioprine, and the myclophenolate mofetil. Those are great. It looks like my little, it popped up on the next line, but dupilumab, of course. I had gotten off all my kiddos off of the oral systemics and transitioned over to Dupixent, dupilumab. But some families or some kids are not going to let you do an injection. But again, we know it's approved down to 6 months of age. It's the one that I feel the most comfortable with. And I think most people feel that way. And then the systemic JAKs, again, I think we're going to see those used more and more in everyone, including kids, eventually. And then the other really important thing that you have to treat, so it's kind of like when you're doing a code on a person and they want partial code, like they want you to do the breaths, but they don't want you to do the compressions, you know that that's not going to help them survive. Well, if we're just treating the skin barrier and the inflammation, but we're not treating the itch, we're not really going to get the full effect, because the itch leads to the scratch and the scratch leads to the itch. And then you get this roundabout circle, that itch scratch cycle that all families, describe quite well. So sedating antihistamines, it's a mixed bag about what people feel about them. But in my personal experience, I feel like the sedating antihistamines, hydroxyzine, does help. You can, become less sensitive to those. So sometimes you do have to adjust. And remember, the kids are growing. So sometimes if you've seen them when they were 6 months and you prescribed it, then they're going to need a bigger dose when they're 2. So don't just keep refilling it and not calculating the amount. Cyproheptadine is my second line therapy. It does help kids gain weight. So a lot of these kids, because they're not sleeping and they're burning more calories by itchy scratching, and they sometimes have limited diets because of allergens, cyproheptadine can give you the benefit of weight gain in some of these low weight kiddos. And then doxepin orally is a great third line. If I'm thinking about doing systemics in a young one, I will a lot of times talk about doxepin, but it is quite concentrated and it's easy to overdose. So you have to have a family that you trust and will know how to dose that. Really, the non-sedating antihistamines have not shown to be very effective. Only if there's other atopic disorders do I give that. So if I have a kid that gets a lot of bug bite reactions, I think that cetirizine is great to have on board. But they've really shown that it doesn't help with the itch of eczema. Also, the leukotriene inhibitors, the Singulair montelukast, has been shown to have significant behavioral issues. And again, I think our kids are a little bit more able to be triggered into behavioral issues because they're tired already. So not really been shown to be effective. And again, the itch is associated with disrupted sleep. They can't then concentrate in school. So a lot of them get overdiagnosed with ADHD. And then again, that leads to a lot of stress, which don't underestimate that for the families, and really try and address that, not just with the medical agents, but saying, I know this is really hard, referring them to advocacy groups, referring them to Made a Masterpiece, National Eczema Association. And then certainly don't forget that we have friends in psychology, and a lot of people are doing online counseling. So that's a great way to do some kind of behavior modification therapy. And food for thought. So again, food allergies are really not a huge issue in our kiddos. If they're having hives, that's when I think it's important, or urticaria, for them to be referred for food allergy testing. But I also worry about potential food allergies if I have a kid that's failing to thrive, they're not gaining weight because their GI tract might not be absorbing. And again, if their GI tract isn't absorbing, they may have diarrhea. So if I have a kiddo that has diarrhea with severe atopic derm, I usually refer them. But we do know that if you just have strictly atopic derm, the reason they're having it is a skin barrier issue. And again, let's focus on where the problem is and not add restriction diets onto these families that are already having to do so much to keep their kids healthy. And they've shown that there's no benefit in delaying solids past 6 months of age. And then probiotics, basically in the Cochrane review, like with the meta-analysis, they showed that it's really not highly effective in everybody, but they do carry a small risk. So I really let families try probiotics. And sometimes I recommend, especially if they're having GI symptoms. And again, most of them are not going to cause a problem. The other thing for sleep that I forgot to mention is melatonin. Sometimes, and again, there's question about introducing that too young, and, you know, then changing their sleep-wake cycles and their circadian rhythm. But I do find that families are willing, and I start with the least amount of melatonin for the itch if, you know, I have somebody that really doesn't want to do medication. And then last caveat here as we kind of wrap up, but allergy testing, and again, it's really better to do blood testing than prick testing because our kids we know have reactive skin. So again, if they do go to an allergist, I have a few that, you know, I work with closely and I've talked to them. And I really think that they get a lot of false positives with prick testing just because their skin sensitivity. So I think the blood testing is more reliable. And again, use common sense. There are a lot of kids that are sensitized to dust mites. So you can, you know, recommend mattress covers or low pile carpet in the sleeping areas. Then as far as pets, a lot of families will ask about this. So they actually showed that even if your prick test positive for a dog, that there's no increased risk of atopic derm if you have a dog in your house. But if you're prick test positive for a cat, it actually increases your risk of atopic derm 13-fold. And it seems like birds might be protective. So if they want a pet, I usually tell them to get a dog over a cat that's, you know, low shedding. And then the other thing is a lot of them will have pets already that are a dear part of their family. And I find that even if they get rid of the pet, their atopic dermatitis doesn't go away because that's really not what's causing it. Again, it's a skin barrier. So if we're doing everything right and we still can't get it under control, then I might think about the pets. But for the most part, they'll just lose a part of their family and their kid will still have eczema because it's a skin barrier. So in the end, treat them the way you would want to be treated. Treat them like they're your niece or your nephew or your brother or your sister, because these families are suffering, like we talked about, the misery of living with atopic dermatitis. So I hope these give you some good pearls. I know that I spent a long time going over this, but it's so important to know just general atopic dermatitis, because again, 20% of the kids that you see in your life, not just in your office, but in your family, are going to have atopic derm. So again, people don't know what they don't know, and it's our job to teach them, and it's my job to teach you. So I hope you learned a lot, and I am looking forward to seeing you again in November. We're going to move on from the dermatitises to something a little bit different. We're going to be taking a break next week. We do have an event here at Sagis for the local derm kids. So we are taking a break next week. We'll be back on November 9th. And then the kids are going to be out for holiday break. So basically T4 is going to be taking a break for Thanksgiving and Christmas and coming back strong in the new year. So again, go back and look at the pre-recorded things if you haven't already. And certainly always reach out if you have any questions at pdderm@sagesdx.com. Have a good night, guys. Bye.